Please keep it in mind to avoid SGLT2 inhibitors, especially during Ramjan fasting. And either you can go for the metformin, either you can go for the glyclazide because it is short acting in this thing, and either you can go for this DPP4 inhibitors, avoiding the SGLT2 inhibitors because one of the deadly side effects. Wait a minute. You can do. And during Ramjan fasting, we generally find this dehydration because of the hot sun and all. We are supposed to discontinue the SGLT2 inhibitors. It's a mandatory dictum. Okay, and you can see here the SU overall, the left hand side, the bar diagram shows the comparatives, this thing between all these drugs, the overall SU and the glyclazide and the glimepiride and the glibenclamide and the sitagliptin. And on the right hand side you see this this is the incidence of symptomatic hypoglycemia during Ramjan in as it is. You find that the lowest is with either the glyclazide or the gliptins. I said already, I have told you, gliptins have got the lowest incidence of hypoglycemia. Either the vildagliptin or the sitagliptin or the linagliptin or the allogliptin or the danagliptin, whatever it may be, they got very less incidence of the hypoglycemic episodes. And glyclazide during Ramjan, you can see the many original papers being published in the multiple international journals. Even fasting patients can safely maintain euglycemic the glycemic control with the evening administration of glyclazide MR. That is the two times. The morning one is called the Sairi and the evening one is called Iftar. The time when you start fasting is Sairi, and they have the food before, like somewhere around some 4 a.m. they have, and it starts from 4:30 or somewhere else, and it ends up by 6 o'clock or 7 o'clock, and that is the time to break the fast, and that is iftar. And if you can give this glyclazide at the time of breaking the fast, where they take fruits and the dates, the khajur and all, you can take this and you find a very very low incidence of this particular MR, being the modified release, the sustained release, the extended release of glyclazide will not let the patient down with the hypoglycemia. So, and proportion of the patients reporting equal or more than 1% symptomatic hypoglycemic episode during Ramjan was very low, that is 2.2%. And the guide study, the glyclazide versus glimepiride, already we have seen this, and 50% of fewer confirmed hypoglycemic episodes with glyclazide MR compared to glimepiride. You can see the episodes like glimepiride, it is 8.7 and the glyclazide MR is 3.7. And the episodes with the glyclazide is only the 22 episodes, and with glimepiride it is 56 episodes. And safety towards euglacemia, the glyclazide cardiovascular outcomes, glyclazide and cardiac safety, and you know how the sulfonylurea, the mechanism of action, they act by sticking to the cell membrane, the sulfonylurea receptor, one specific cell membrane, and they start squeezing the insulin from the beta cells, and glyclazide XR compared to the other sulfonylureas, and it doesn't interfere with the ischemic preconditioning. Even the glimepiride also doesn't interfere, whereas the worst culprit which interferes with the ischemic precondition is the glibenclamide actually. And these two drugs, actually glimepiride is considered to be the rose without thorns actually. So this is all the statistical. The Danish registry shows glyclazide has lower cardiovascular risk than other insulin secretagogues. sulfonylureas. And again, the statistics, the glyclazide has lower all-cause mortality and CV-related mortality risk. And the glyclazide did not increase the risk of stroke. And the advanced study, the major macro and microvascular events, you can see the relative risk reduction is 10%, and the 10% of relative risk reduction of combined major and micro and macrovascular events seen with this particular glyclazide. And glyclazide and renal outcomes. The lower risk of doubling of creatinine with glimepiride, and you can compare this with this the glyclazide. The blue is the glimepiride, and the glyclazide is given in the red. That is a doubling of serum creatinine in the chronic kidney patients in the stages of the 1 and 2. That is, you can see the clear difference between the glimepiride and the glyclazide, and you can see on the right hand side also the doubling of serum creatinine in chronic kidney disease, that is diabetic kidney disease, stages 3, 3A, 3B, 4 and 5. You can see the difference. You can see clearly the curves getting started separating from the beginning itself, and at the end you can see the difference in the outcomes. So the number was 4,486 of type 2 diabetes patients with preserved renal function, and a 21% reduction in the diabetic kidney disease, that is seen in the intensive arm of advance, and 65% reduction in the risk of end-stage renal disease or the end-stage kidney disease, and 20% reversal to normal albuminuria. So you can see the comparison, the reduction in the ESRD with the standard therapy or the intensive therapy until the 0 weeks to 66 weeks, and remission to normalization, that is you can see the normal albuminuria, the microalbuminuria and the macroalbuminuria and the ESRD. You can see the reversal by 20%. And 46% of reduction in ESRD, and you can see very clearly here the advance and the advance ongoing, and the better outcomes with preserved kidney function. You can clearly see the in the bar diagrams. And this is KIDOKI, that is Kidney Disease Outcomes and Quality Initiative. That's an international the authority for the kidney diseases, actually, that's based in US. Then the National Kidney Foundation, and you can see the estimated glomerular filtration, where glyclazide can be used at any point of this particular if the EGFR is less than 30 also, you can be the glyclazide can be used, and with 30 to 45, that is the stage 3B also, you can use the glyclazide, and 46 to 60, that is stage 3A also you can use. So obviously you can use it in 1 and 2, 3A and 3B, and less than that also you can use, where the glimepiride has to be used with caution in both these things, and you should avoid, because it's a long acting one. So all the long acting, even the insulin also, you better try to avoid this long acting basal analogs or the NPH in kidney failure. To prevent the unexplained hypoglycemias, you go for a shorter ones like rapid acting insulin or the short acting insulin. Even the molecules, when you select, you have to go for a very short acting molecule. The only one long acting molecule that can be used in all the stages from 1, 2, 3A, 3B, 4, 5, and during the dialysis, and after the dialysis, and during the transplant, and after the transplant, is only one, that is the DPP4 inhibitor, the linagliptin, which is called the real renal gliptin. That is the only drug along with the insulin that can be used very safely in all the stages of the kidney disease progression, including the dialysis and the post transplant also. So here what they concluded is glyclazide can be used without dose adjustments in CKD 3, 4 and 5. But you have to be very cautious when you are using glyclazide in 4 and 5. You have to be you use it with caution. You need to reduce the dose, because all of a sudden the patient gets into the what is called as typically the unexplained hypoglycemia is the classical feature of the chronic progressive kidney disease. And the glyclazide weight neutrality. So if we take the landmark trials like VADT and the ACCORD and the ADVANCE, no significant weight gain in ADVANCE. You can see this. The max by max, there is hardly any in ADVANCE, but ACCORD it's around plus 3.5 kg, and that is the VADT shows they increase the weight by 8.1 kilogram at the end of the study. And weight neutrality over 5 years, you can see the mean weight, and in the ADVANCE, the yellow line is the ADVANCE graph with glyclazide MR until the 5th year. You can see it is fluctuating definitely, but at the end of the 5 years of the study, the ADVANCE, there is no increase in the weight or decrease in the weight. So it shows that the molecule gliclazide MR is the weight neutral molecule. I totally agree with this, because I have seen in my clinical practice the last almost 3 decades I have been using this gliclazide. And better weight control and the body mass index control during the Ramjan fasting. This is, you can say, see this original research article being published in Diabetic Research and Clinical Practice. You can see a real world study in patients with type 2 diabetes mellitus treated with glyclazide modified release during the Ramjan fasting, the Daya Ramjan, that is study is Daya Ramadan. So you can clearly see it is the weight or the BMI. When there is no change in the weight, obviously the BMI remains unchanged. And to summarize the things and the take home message, glyclazide is sulfonylurea receptor 1 specific sulfonylurea causing biphasic insulin dependent glucose secretion, and gliclazide is at least as effective as glimepiride, either as monotherapy or in combination, and the gliclazide helps in navigating patients safely towards glycemic goals with low risk of hypoglycemia as compared to other sulfonylureas, and gliclazide has favorable cardiovascular and renal outcomes and is weight neutral, and gliclazide helps in glycemic control while fasting and does not need a dose adjustment in the diabetic kidney disease or the chronic progressive kidney disease. And one more thing, the core message I just wanted to give to this the sponsors of gliclazide is like Carolina, because the landmark trial in the history of sulfonylureas, never ever done in the history of sulfonylureas. The molecule glimepiride was compared with that of linagliptin, and the final inference of Carolina is that was done by this particular the Boehringer Ingelheim people. So the molecule linagliptin has shown non-inferiority when compared to glimepiride with regards to the weight gain or the weight neutrality and the cardiovascular events. That was the inference of Carolina, and I request the sponsors of this particular gliclazide molecule to have an international comparative study. These are all the placebo controlled, double-blind randomized controlled RCTs. So I request the sponsors of this particular company to have a landmark trial like Carolina, so that you can compare this with any DPP4 inhibitor or with any SGLT2 inhibitor or anything else. That should be done on the in the international level, like Carolina, then you have the established data, a comparative study like, okay, linagliptin versus glimepiride. So you take some other gliptin, you compare with glipizide, you show the non-inferiority or the superiority, then everybody will come to know the good effects of glyclazide. That's what I conclude by saying thank you so much for your patient listening. Let me see with this. Yeah, see, I'm sorry. There are some more slides, okay? The glyclazide, the sulfonylurea with a difference. The unique mode of action, the pancreatic at the level of pancreatic beta cells, and then the beta cells sulfonylurea receptor 1 specific, and the control and the pulsatile insulin secretion. And when it comes to efficacy, on par with other sulfonylureas, and treatment durability, with less incidence of hypoglycemia, that makes the lower risk of hypoglycemia, keeping the renal safety, keeping the cardiovascular safety, and keeping the weight neutrality. And this becomes an ideal choice in type 2 diabetes management in case sulfonylurea is being considered. In our country, the second drug will obviously be the sulfonylurea, to the best of my knowledge, and I don't think anything holds good in place of sulfonylurea after the metformin. Metformin is I tell you once again, my dear friends, metformin is the mainstay of therapy. That is the first drug of choice in the management of type 2 diabetes mellitus, unless otherwise it is contraindicated. And in our scenario, we cannot go for straight away like, okay, what ESC has said, the European Society of Cardiology, and with in association with the European Association for the Study of Diabetes, ESC bar EASC guidelines in 2019, what they said is, if the patient is at risk of the atherosclerotic cardiovascular disease or the established atherosclerotic cardiovascular disease, forget about metformin, you straight away go to SGLT2 inhibitor or GLP-1 receptor agonist, or you can combine both. But we are not in a scenario to either use GLP-1 receptor agonist, which is so costly, like each pen costs around some, Victoza costs around some 4,500 rupees, and even the SGLT2s are around some say 60 rupees each tablet. So for us, the second drug would obviously be a sulfonylurea, but be wise to choose the second drug. Either you go for gliclazide, or you go for glimepiride, or you go for even glipizide also. Even the poorest of the poor, you go for glibenclamide. But one thing only you have to keep in mind, because the glibenclamide produces lot of serious hypoglycemic events, so it's better you stop the usage of glibenclamide when the patient is above the age of 60 years, and below that we can use if the patient is, it is the drug of choice for the poorest of the poor. That is the most economical drug on the earth, even economical when compared to the metformin also. So you can use it as long as you monitor the patient, as long as the patient doesn't get into the serious hypoglycemias. You can use any sulfonylurea, that is your choice, but use with some judicious caution. That's what my appeal is. And thank you so much for your patient listening. And if there are any questions, you can type in the chat box. I am glad to take your questions. Need not be particularly related to this gliclazide. You may ask me about glimepiride or glibenclamide or anything, even other drugs also, either the treatment of diabetes mellitus, type 2 diabetes, or the treatment, any topic in the diabetes. Feel free to ask me by putting your questions in the chat box, please.